Thank you everyone for dialing in tonight to the next episode of the 2023 State of Play series. For those of you on Zoom, you'll probably see a notification about the meeting being recorded. Please just click OK or agree and that box will disappear. First, I'd just like to have an acknowledgement of country. So MND Australia acknowledges the traditional custodians of country throughout Australia and the connections to land, sea and community. We pay our respects to their elders past, present and future and extend that respect to all Aboriginal and Torres Strait Islander peoples today. And I'd like to acknowledge the Wiradjuri people on whose land I am and pay my respects to elders past, present and emerging and extend a welcome to any Aboriginal and Torres Strait Islander peoples on this call tonight. So tonight, we're going to hear about two sort of fairly divergent themes of research that kind of loosely connect around the mouth, I guess. We will hear from Dr. Brooke-Mai Whelan, who is a speech pathologist at the University of Queensland, and we'll talk about her work into predicting and hopefully reducing the impact of speech decline. And we'll also have Dr. Derik Steyn, who's also from the University of Queensland, who will talk about his work, which crosses the lab and the clinical nexus and looking into the appetite and weight changes we see in MND. We also will have the additional benefit of Steph, who's a PhD student in Derik's group. And she's going to speak about some very recent results that she's recently published. So hot off the press, you'll just jump in for a few minutes to tell us about her latest data. So as previously, each presenter will talk for about 20 minutes and then we'll have a combined Q&A at the end of the session. Please submit any questions you have if you're on Zoom through the chat or the Q&A function, or if you're watching on Facebook, you can do it through the comments on that. And look, you don't need to wait to the end. Just throw your, as soon as you think about a question you want to ask, just chuck it in the chat or the Q&A and we'll collate them all for asking at the end. You don't need to wait till the end to ask your questions. So that's it from me. You don't hear any more from me. So I think Derik is going first. So all yours, Derik. I'll just stop my share and you should be able to start your screen share. Perfect. You're all good to go.
Perfect. So just thank you very much, Gethin, for having us. And also thank you for this opportunity to Steph as well. It's always nice to have somebody who's just recently published results present, but also in this case, somebody who's still doing their PhD and very much committed to doing MND research. So I can't see anybody online, so it feels like I'm just talking to myself, and that's okay. But for those of you who haven't met me, my name is Derik Stein. If you get an email from me, it comes from a guy called Frederick. I'm a biomedical researcher at the University of Queensland, and I've been working alongside my team looking into the lived experience for MND for since 2014. We've been doing a lot of research to try and understand this thing called heterogeneity, why people with MND are so different, and then of course trying to learn from that to develop ways of improving quality of life, extend survival. And we're also using that to try and figure out exactly what causes MND and how we can change the outcomes for people living with motor neuron disease. So one of the things that we focused on very early on in these studies was this association between weight loss, progression, and survival. And to us, this was a very important observation early on because it was very clear from several publications that people who tend to be leaner, people who tend to be of a healthier or even below healthy weight, tended to have a much faster progression, whereas people who are a little bit overweight tend to have longer survival, better outlook. And of course, this goes against our general thinking around weight. We always talk about being overweight as being bad, but in this instance, it certainly seemed that people within the overweight to obese category tended to do much, much better. And following from that, there was a lot of literature and a lot of evidence out there to suggest that losing weight after diagnosis, at the time of diagnosis, tended to be a bad sign. And I've just put a list of some of the papers that show this, and you can see that it's a very consistent finding in the literature that weight loss tends to be a bad sign. And of course, we wanted to know why do people lose weight and how we can help them maintain their weight. And that was really a motivation for some of the studies we started doing very early on. Apologies for that. So the first thing we started doing was really thinking about, well, exactly, what might be causing changes in body weight in people with MND. And of course, we also know that at the onset, when people start developing MND, there is this idea that their body starts to burn energy in a very different way. And there's people who are familiar with research in MND, they would call this thing hypermetabolism. So hypermetabolism, generally speaking, is the change in the body where the body starts to use energy a lot faster than it would normally do so. And in some other conditions, hypermetabolism, this increase in energy expenditure, is associated with weight loss. And of course, at the time, the suggestion was that when a person develops MND, their body starts burning through their energy far more intensively, and that this increase in energy expenditure effectively tips the scale so that they start to burn through their fat stores, and this in turn would contribute to weight loss. And it makes sense. So of course, it hadn't been validated, hadn't been confirmed. And so we thought, well, the best place to start if we're going to change this is to double check that this actually is the case. And this is the kind of research space that we work in. And we're very fortunate to work alongside Robert Henderson, who's a neurologist at the Royal Brisbane Women's Hospital. And this happens to be Rob lying on a bed. It's inside one of the rooms that we do our research in. We've got 2 of these rooms at the University of Queensland. In the back, you've got a machine that looks a bit like an egg. That machine uses air. In fact, it looks at the air that you push out of the chamber, air displacement, to make a prediction on how much muscle you have and how much fat you have. And then Rob is lying on a bed and he's got a canopy over his head and he's breathing into that. As he breathes into that, we can actually measure how much energy he's using. And using these 2 pieces of equipment and working with people with MND, we had people come in, we monitor their body weight change and their changes in fat mass and fat-free mass over extended periods of time. And we also measure how much energy they use. And the idea there was that we can figure out who's using more energy and then see if those individuals are at greater risk of losing weight. And also, if they do lose weight, are they losing muscle or are they losing fat? Now, this was in 2015 when we first started this study, and we have published several papers from the results from these studies. And the very first paper we published in 2018 was really just looking at the prevalence of this change in metabolism. But as part of that, we also looked very carefully at what happens to these individuals. And we tend to break people up into 2 categories: those who experience that big change in energy use, and then those who don't. And the graph here is just a summary of those 2 groups. So the red group is the group of people who experience change in metabolism, and the blue group are those individuals who don't. And as you can see, the 2 lines, and this is just body weight, tend to follow on top of each other, which would suggest that having an increase in energy use does not actually contribute to weight loss over time. And that was a very interesting observation because it was unexpected. And if you look at a person's composition, in this case, we use body mass index, which is a kind of an assumption of body fat. You can see that, again, there's no difference between those 2 groups of individuals. And very importantly, when we look at percentage fat mass, you can see, again, that there's no difference between those 2 groups of individuals, except for the fact that people who have this big increase in energy expenditure tend to have a little bit more body fat, which was really interesting. And again, not what we expected to see. And so from these studies, it was very obvious that burning through more energy doesn't necessarily contribute to weight loss in people with motor neuron disease, which kind of forced us to rethink our initial hypothesis. If it's not how the body's using energy, maybe it's how people with motor neuron disease are actually accessing energy. How much food are they eating, and are they maintaining their energy requirements? And so we immediately shifted our attention towards appetite, and we started looking very carefully at changes in appetite in people with motor neuron disease. Now, one of the very first studies we published on this came out in 2019. And in this particular study, we worked alongside 64 people with a diagnosis of ALS, and we compared their responses to a number of questionnaires, but also tests alongside 45 people who didn't have ALS. These were family and friends of those patients. And I'm going to just take you quickly through the results of the study just to kind of set the scene. But this was one of the very first studies really to look at what happens to appetite in people with motor neuron disease. the first thing we realized when we started collecting information is that there's a lot of variation in people with motor neuron disease. And this graph is just a very simple representation of an appetite score. So as numbers go up, people tend to have better appetite, and as numbers go down, people tend to have worse appetite. And what we found was that within people with MND, about 30% of individuals presented with a score that would suggest that they've completely lost their appetite or that they have very poor appetite. And if you compare that to the people who don't have MND, we found that people with MND were about 3 times more likely to present with loss of appetite. Now, what makes this really important is that we also then looked at what happens to body weight and changes in body composition. So this is fat mass and fat-free mass over the period of time that they came back for follow-up visits. And here we now have the people in green. These are the people who have got intact appetite. And we have the people in red. These are the people who present with loss of appetite. And you can see very quickly that the people who present with loss of appetite are those individuals that tend to lose weight much faster over time. But if we look at their actual fat mass, you'll see that these are also the individuals who tend to lose fat mass, suggesting that they are the individuals who are not necessarily eating enough to maintain their body weight, and specifically to maintain their body fat stores. And so to make a very long story short, we identified loss of appetite as a potential cause for body weight loss in people with MND. Now, what's really important about this observation was that we also identified several misnomers, so assumptions we had made that weren't necessarily founded within the results of the study. The one assumption we made was that people that had bulbar onset disease, people who potentially had difficulty chewing and swallowing, would be the ones at greater risk of losing their appetite and also at greater risk of losing body weight. And what was really interesting was that the study would suggest that having bulbar involvement, having that change in your ability to eat and swallow, did not have an impact on appetite as well. And so it was a very unexpected finding. And it also suggested to us that maybe other changes occur in MND that might impact a person's appetite that's not necessarily related to their ability to swallow. Now, this in itself is a big problem, because we know that appetite is a very complex human behavior, and many, many factors can contribute to appetite. And if we started looking through the literature, we started finding evidence of some of the changes that might occur in people with MND that might impact their appetite. For example, a small proportion of people actually experience changes in their taste, and sometimes even loss of taste. As I've mentioned, there are some people who present with onset in bulbar symptoms, and of course, the majority of people with MND may experience changes in bulbar function at some point. There's also good evidence to suggest that the gut is changing in motor neuron disease, and this might have a big impact on appetite. And then there was a range of physiological factors, so factors associated with central mechanisms. The brain controls appetite, but also peripheral mechanisms, the body sending signals to the brain that might impact appetite. And then, of course, there are also those psychosocial factors, things such as weakness and inability to necessarily prepare a meal or bring the food to your mouth, social isolation, fatigue, and all these other factors that might impact a person's willingness to engage in a meal or their ability to access food. And of course, all of these factors can impact a person's appetite. So this prompted us to really think about how are we going to address this, and what can we do if we figure out exactly why people with MND might lose appetite. Now, on this slide, I have 6 faces. So these are the 6 people that are currently working on these questions within our team. And I'll go through very quickly who these individuals are, but very quickly, our priorities are, how might changes in appetite and diet impact people living with MND? We're looking at what are the psychosocial factors that might impact appetite, what are the biological mechanisms that might contribute to changes in appetite, and also, once we identify what might be contributing to appetite loss and how this might impact body weight regulation, can we target that? Can we help to improve appetite, to not only slow down progression of disease, but also to improve quality of life? So before I go into some of the recent observations, I just want to point out that many of our studies are conducted online. And so even if you're all the way in South Australia, for example, and you're watching tonight and you want to be part of this research, you can certainly be part of the research. If you want to get involved, Dina or Dee is the person in our study that coordinates most of these studies, and you can reach out to Gethin, and I'm sure Gethin wouldn't mind passing on your details, and then we can happily engage with you. And if you want to be part of research, in particular this type of research, we would definitely welcome your participation. So one of the newer additions to our team is Amber. Amber first approached me last year, but she officially started her PhD at the beginning of this year. Amber is an accredited practicing dietitian and nutritionist, and she is very interested in understanding what people are eating with MND and how their diet might impact progression and outcomes. And I guess core to that understanding is that MND and diet is really part of the same equation. It's a two-way street. We know that having MND can certainly impact your diet, but we also suspect that your diet can impact MND. Now, I'm not going to go through all of the studies that Amber is doing. She's very much focused on fats in diet and MND, but she has had an opportunity to look at some of the historical data that we've collected on diets and how that might impact people with MND. She is presenting a lot of this research at the end of the year at the Australia-New Zealand MND Symposium in Wollongong. And so she will definitely present these results in far more detail. But very quickly, what she did find was that people with ALS that meet or exceed their estimated energy requirements. So this is the amount of calories that a person might need adjusted for their resting energy expenditure, for their activity, and also in this case, adjusted for the level of disability they might have as a consequence of MND. She found that people who met or exceeded that were more likely to have bulbar onset disease or bulbar involvement. So again, this is coming back to that initial study, suggesting that having bulbar involvement doesn't necessarily impact appetite. She also found that those patients with higher percentage of the EER, so the people who actually consume more energy than they needed, experienced greater bulbar dysfunctions as disease progressed. And again, that goes against our initial notion that having bulbar onset disease could predispose you to weight loss. And we've sat down and we've talked about this, and we suspect what happens here is these are the people who are more likely to engage with the dietitian. These are the people who are more likely to be approached by the clinician to suggest that they get support from a dietitian. And so it would suggest that maybe the other individuals, those individuals who are not meeting the energy requirements, are not those individuals that are aware the diet is important, and they may not be the ones who are being approached or encouraged to see a dietitian. So that kind of brings us to some of the factors that might impact appetite. I want to quickly just focus on one aspect, which is called psychosocial factors. And we use psychosocial as a term to kind of summarize a range of human emotions and other factors that might contribute in a person's everyday life. And in this instance, Sally is another PhD student, a candidate in our group. Sally's also a allied healthcare professional, and she has a very long and very productive history in caring and looking after people. And Sally has joined the team to kind of look at the lived experience and all the factors that might actually impact an individual. And as part, she's also had a look. Part of this, she's also had a look at what might impact appetite from a psychosocial perspective. And she has looked at data from 75 people with MND and 40 people who don't have MND, again, family and friends. And she compared appetite to a number of other outcomes, in this case, looking at questionnaires on fatigue, anxiety, and depression, and hope. And the idea there is to try and understand exactly how things like fatigue, anxiety, and depression, as well as hope, might have an impact on a person's appetite. And again, Sally's also going to be present at the meeting at the end of the year, and she can present the details of her study in greater detail. But very quickly, what she found was loss of appetite, fatigue, and measures of depression tended to be greater in people with ALS when compared to their families and friends. And what's really interesting was that people with ALS, their appetite tended to worsen as their fatigue became greater, but also as scores suggesting depression tended to get greater. And so suggesting that appetite in this instance is very much related to fatigue and depression. And the other thing that Sally found was that fatigue was greater in people with ALS who tended to also lose their appetite. Now, we're not saying that these things are related. We're simply saying that there's a correlation there. but it would suggest that fatigue and depression might contribute to loss of appetite in this particular cohort of people with ALS and people with MND. And so these are the psychosocial factors that we are currently assessing, but we're also looking at exactly how MND might impact the rest of the body. And to do that, we've taken on two approaches. So one is to look at mechanisms of appetite regulation in the brain, and the other one is to really look at how the body sends signals to the brain to encourage hunger and, of course, appetite. And whenever I talk to my students and whenever I lecture on this, I always remind people that hunger is more than just a gut feeling. Hunger really is a process that is controlled by the brain. And right at the beginning, right at the start of that process is a structure known as the hypothalamus. It's a very tiny organ deep in the center of the brain. It's about the size of an almond. And what it does, it receives information from the body, and then it starts sending information everywhere up through the brain. And it's one of the first areas of the brain that helps us make decisions, facilitate things like taste and smell, learning memory, the pleasure we receive from eating, and all the things that contribute to our motivations and wanting of food. And Jaren had a very close look at this hypothalamic structure in people with ALS. She's published this work earlier this year. And so if you're interested, you can scan that QR code and have a look at the paper. But very quickly, what she did is she just looked at the volume of this little structure in the hypothalamus and how it is impacted in ALS. And she found that unlike previous reports that would suggest that there was an atrophy or loss in the volume of that area, that some people with ALS tended to have very low hypothalamic volume, and that correlated with having a low BMI. So these people are the individuals that would suggest to have atrophy in this brain area that leads to weight loss. But she also found that in some people, lower volume of that area of the brain tended to be associated with having a greater body weight. And this kind of makes sense to us. This little part of the brain is involved in driving appetite, but it's packed with different neurons. And some of those neurons would make you hungry, and some of those neurons would make you really full. And the prevailing hypothesis is that the disease MND might impact the hypothalamus and selectively modify the distribution of those populations of neurons. Some of those neurons will survive, making a person feel less hungry. Some of those neurons will survive, making people feel more hungry. And so there's the subset of people who might go on to gain weight, a subset of people who might go on to lose weight. And of course, unfortunately, those who go on to lose weight would be the ones at greater risk for having a more severe and faster progressing disease. And as a consequence, we also found that those individuals with lower volume and lower body mass, unfortunately, were the individuals at greater risk for having fast progressing disease, resulting in earlier death. Now, that's not where we stopped. We know that the hypothalamus is just the beginning of a bigger network of areas in the brain that control appetite. And so Jaren has gone on to look at how different areas in the brain that's associated with appetite control, hunger, is impacted in people with MND. And she's got some really interesting data coming out of that study suggesting that there are distinct differences in the brains of people with MND compared to people who don't have MND that might impact perceptions of hunger and satiety. And we're also very fortunate that the MND Australia, in collaboration with MND Foundation, has funded a study looking at how MND specifically impacts the different cells within the hypothalamus. And in this case, we're looking across the spectrum of ALS and FTD. ALS tends to be a disease that's associated with loss of body weight because of loss of appetite, whereas in FTD, we tend to see a gain of weight due to an increase in appetite. And of course, there are also those individuals in between who might present with ALS and eventually develop FTD, or those individuals who present with FTD and eventually might develop ALS as well. And the idea there is if we look at these cells, which cells have been impacted and how those cells have been impacted, we'll learn more about the disease and the underlying mechanisms that can have a big impact on how the person might perceive food and how this might impact their progression. Now, I think I've said a lot already, and so I'm going to hand over to Steph. Like I've said, Steph is a PhD student in our group. She's currently in Singapore doing some wonderful work. But before she left for Singapore, she actually had a look at some of the hormones in the body that contribute to appetite. And I think it's most appropriate for Steph to tell us a little bit about what she has found. So Steph, are you there?
Yes, I am. Hello.
Okay, I'm going to hand over to you now, Steph.
Cool. Thanks, Derik, and thank you everyone for letting me speak today. So obviously there are a lot of different hormones which can contribute to appetite regulation. But the three that I've chosen to focus on in the paper that came out at the start of this month were ghrelin, leptin, and LEAP2. Ghrelin is the main hormone in the body that drives hunger, and it's produced mainly in the stomach, binding to the hypothalamus to increase these food-seeking behaviors and increase body weight. LEAP2, on the other hand, is mainly produced in the liver, and LEAP2 competitively binds to ghrelin's receptor, stopping ghrelin from being able to bind its receptor, and effectively blocking this appetite-stimulating behavior, and you would expect that this would decrease body weight. The third hormone, which I'm not going to talk about too much today, but it is in the paper, is leptin, which is produced in the fat cells of the body. So the people who have more fat have more leptin. This leptin binds to its own receptor in the hypothalamus to decrease food intake and effectively decrease body weight. So if you're interested in this paper, please scan the QR code. You can read it, it's open access. So what we did to measure the effects of these hormones is we took blood from 43 controls and 46 patients with ALS. We collected measures of their body composition, so their height, weight, fat mass, and fat-free mass. And for the ALS patients, we collected measures of their ALS-FRSR. We also followed up a subset of these ALS patients over time, about every 3 months, measuring these body composition and clinical measures as well. And for all of our ALS patients, we collected their survival data. So what we found was that ghrelin was significantly lower in ALS patients compared to controls. And this is something that has been published previously. We also saw that LEAP2 was the same, if not higher, in patients with ALS, meaning that the ratio of this inhibitory hormone to ghrelin is much, much higher. So what we would expect is that you're having a lot of inhibition of ghrelin, and so a lot of inhibition of hunger, and so reduced appetite in patients with ALS. But we didn't really know how this was actually affecting people. So we looked at some correlations between the levels of these hormones and body composition. And there's a lot here, but I'd like to sort of point out that in both patients with ALS and in controls, ghrelin is negatively correlated with BMI. So patients who have increased BMI tended to have lower ghrelin. Similarly, patients who have a higher LEAP2 ghrelin ratio had a higher BMI as well. So at least to some extent, we know that the mechanisms which drive the amount of ghrelin that's released are somewhat being conserved. But we still didn't know from this what the effect of having lower ghrelin actually would be on the patients. And if we look at the survival, we actually see that patients with higher ghrelin had significantly poorer survival than patients with intermediate or lower ghrelin. This is kind of not what we were expecting. We would think that since ghrelin drives appetite and maintaining your body weight is a good thing in ALS, we would expect that patients with high ghrelin would have better outcomes. But it actually makes sense that this isn't the case. Because if you look at this particular group of patients with high ghrelin, we can see that at the time that we measured their blood, they had much, much lower fat mass than the other groups of patients. And despite having this increased ghrelin signaling, they didn't have any increase in their increase in their fat mass over time, and actually lost a bit of weight. So why is it that even though they have this increase in hunger signaling, these patients don't gain weight? Well, it could be due to dysfunction in the hypothalamus, which ties in with what Jaren has been doing. The other thing to keep in mind is that even though these patients had higher ghrelin than the other patients in this cohort, they only had about the same, if not lower ghrelin than their age and sex matched controls. So what this means is that they don't have the increase in ghrelin signaling that we would expect for people who are at risk of malnutrition. Meaning that potentially the ghrelin that is being produced in the body is not necessarily enough to maintain appetite in these patients. And this leads on to other work that another PhD student in our group, Hao, has been working on. So what his PhD focuses on is whether we can treat people with ALS, and what he's done is treated mice with various compounds that bind to ghrelin receptor to drive appetite and hopefully help these patients, and at this point the mice, to maintain their body weight. And what he found was that by treating the mice with a particular hormone that binds to ghrelin receptor in the hypothalamus, the mice have a dramatic increase in their body weight. And this can be seen in their fat percentage as well as their muscle mass. And this is also reflected in their grip strength, meaning that they have a delay in functional decline when they've been treated with this hormone that mimics ghrelin. So this work is ongoing, but yes, sounds very exciting, I think. So to sort of sum up what I've been talking about and what Derik's talking about, is body weight regulation in MND is very complex, and we can't just look at one particular aspect. We need to look at factors that impact how much someone is eating, as well as how much energy they're actually burning. It's clear that appetite loss is not just limited to one subset of patients. So for example, it's not just people with bulbar dysfunction that have a loss of appetite. And there's a lot of different physiological as well as psychosocial factors which impact appetite. To address this, what really needs to happen is that we need to develop better strategies that support each individual with MND to maintain their body weight and maintain their appetite over time, whether this be pharmacological, dietary, or other various interventions such as a PEC. So yeah, big thank you to everyone who has done the work, as well as the participants and funding bodies.
Thank you very much, Steph. So Gethin, I think what we're going to do there is I'm going to stop sharing now. And I believe we're going to leave questions till the end, right?
That's right. Yeah, we'll have a joint Q&A at the end. Obviously, you've probably got to raise a few questions there with people. So, but anyway, we'll shift over to Brooke-Mai Whelan now, who's going to take us through her research, and then we'll go questions at the end. Take it away, Brooke.
Fantastic. Thanks, Gethin, and hello to everyone who is watching online this evening. I am a speech pathologist at the University of Queensland. Recently received a grant very graciously from MND Research Australia to start to research in more detail the dysarthria that's associated with motor neurone disease. I have a long clinical and research history of working with patients with neurodegenerative diseases and associated speech and language disorders, with an emphasis on Parkinson's disease and dementia, and now more recently in motor neurone disease. So, Gethin has already acknowledged country, so I will not repeat that. However, I will talk to what the impact of speech deterioration is in motor neurone disease. We know from qualitative research that speech deterioration is frequently described as one of the most overwhelming aspects of motor neurone disease for people with MND. And this supersedes the loss of even mobility, swallowing difficulties, and this negative long-term prognosis. And as clinical speech pathologists, some of the most frequently asked questions of us, of people and family members of those with MND are, am I going to lose my speech? How long is it going to take for this to happen? And is there anything that you can do to stop me from losing my speech? And at this current moment in time, we are unable to really answer those questions accurately. What we do know is that bulbar onset disease is the phenotype that has very marked implications for speech function. And in some studies, the incidence of dysarthria is as high as 93% in bulbar onset MND. But people with spinal onset disease do not escape the development of dysarthria, with approximately 80% of people with spinal onset disease known to develop dysarthria over the course of the disease. We know a lot about the type of dysarthria, as in the type of speech impairment that presents as a result of motor neurone disease. We diagnose it as a mixed dysarthria type that presents with symptoms of both upper motor neurone and lower motor neurone affectation. And in terms of what we observe as speech pathologists, we commonly see the following symptom complex: that Speech will reduce significantly in rate over the course of time, which also correlates with a reduction in speech intelligibility, or how well a person is understood by their communication partners. We also observe articulatory imprecision, where the way specific speech sounds are produced is less accurate and less clear or precise to the human ear. We also see instances of hypernasality, where the soft palate or the velopharynx, which seals the back of the mouth during speech production, is weak and allows air escape into the nasal cavity, causing the person's speech to be very nasal in quality. And we also very commonly see changes in vocal quality. So this might be things like harshness or hoarseness of the voice, a reduction in volume, sort of a strained, strangled quality to the voice. But these particular features obviously vary from person to person quite a lot, depending on the kind of dysarthria and the stage of disease that a person is at. Unfortunately, there are very few studies that have examined speech decline in MND, which is what really catalyzed my interest in this research area. We know that certainly in bulbar onset MND, that this particular kind of dysarthria is characterized by a very slow speaking rate over the course of time, and that is associated with this reduction in intelligibility, or the way the person is able to be understood with the people that they communicate with. We also know that rate seems to be this predictor of intelligibility decline, so that changes in speaking rate, significant changes in rate, precede this reduction in how well the person is understood. And there is a benchmark in the literature that says that intelligibility will certainly decline at a faster rate in people with motor neurone disease once their speaking rate is less than or equal to about 120 words per minute. So this is sort of a benchmark for speech pathologists to signpost when speech deterioration is sort of about to accelerate or speed up. On average, in people with bulbar onset MND, speech will typically remain functional for around about 18 months following the onset of the very first bulbar symptom. But the caveat around that finding is that we see a lot of variation in the MND community in terms of dysarthria presentation. And each individual patient may, in fact, present a very unique journey trajectory of decline, which makes it quite difficult for speech pathologists to accurately predict how long it may be before the person loses speech, or their speech decline begins to accelerate, and how long it may be before the person loses functional communication. What we do know is that speech decline doesn't appear to be affected by gender or age in terms of the research that's already been conducted. In terms of the role for speech pathologists in MND currently, our role really revolves around maintaining the person's ability to eat safely and to maintain intelligible speech for as long as possible. Speech pathologists routinely provide what we call compensatory strategies. So speech behaviours that can be immediately instated, immediately applied for the person to improve their intelligibility or the way they're understood by communication partners. And an example of that might be to over-articulate or over-enunciate sounds in order for their speech output to be clearer. Our role is also very heavily involved in minimising the risk of aspiration, so again linked to safe eating and drinking practices, to the management of sialorrhea or that thick mucus production, and of course education and counselling around the swallowing and communication impairments that may result because of the disease. Unfortunately, best practice guidelines within Australia, America, and the UK, and really around the world, don't currently provide any recommendations for the management of dysarthria in motor neurone disease. And when I say management, I'm talking about active speech intervention or active speech exercise as a means of preserving speech over time. What we are recommended to do in terms of our scope of practice is to assess and monitor the communication needs and abilities of people with MND, which is of course important, to provide relevant AAC equipment in a timely fashion, and of course to review the ability of a person to use their AAC equipment on a regular basis. It's also recommended that we involve other healthcare professionals to support the integration of AAC systems and other assistive technologies like occupational therapists, where we work very closely in tandem, and also to provide in ongoing support and training for the person with MND, as well as their family members and caregivers as appropriate in terms of how to use AAC equipment and other communication strategies. And whilst these guidelines and the recommendations therein are important, and I'm not denying that addressing these particular issues is not of significant importance for people with MND, what we do know is that AAC uptake within the MND population is not always optimal or preferable. So this was a very early study here conducted in 2004 that looked at a very small cohort of motor neurone disease patients and how they took up low-tech AAC devices and high-tech AAC devices. And what this study showed was, you can see here in the graph, that both high and low-tech communication options were made available across the cohort, black bar indicating high-tech, grey bar indicating low-tech. What the patient's preferences was that they preferred to use low-tech communication devices as opposed to high-tech, with the majority of high-tech device options not being taken. So the take-home message from this study is that it is extremely important to preserve effective communication in MND, that this is deemed to be critical to maintaining quality of life for people with disease and their caregivers. And importantly, that even when people with MND, when their speech is unintelligible or difficult to understand to their communication partners, that people with MND still prefer to use their natural speech as their primary mode of communication. And you can see some of the qualitative results from this study here, such as the statement from participant 15, who said, "I like it very much," referring to the AAC device. "As I said to my speech and language therapist, it's a nice toy, but it's like admitting defeat to not use my own voice." From communication partner 7, so significant other of a patient with motor neurone disease, "I try to talk to her because she'd rather say it rather than write it down or use the light writer. With me, that is, as I've done for many years." So what this indicates to us is that whilst AAC is a solution for the loss of communication, it is not always the preferred option for people with motor neurone disease and their family members. Since that study in 2004, AAC has come a long way, especially with the advent of voice banking. And the results from this study in 2020 indicated that, again, in a small cohort of MND participants, approximately 75% elected to voice bank when given the opportunity. And when that data, or when those people were interviewed and that data was analysed qualitatively, the overarching motivation for voice banking in this group was to preserve their identity, that there is a part of the human voice that certainly very much preserves their identity over the course of time. But for 25% of that cohort, they elected not to voice bank, with the feeling or the thinking that nothing could really replicate their natural voice or preserve their identity once their ability to speak naturally had abated. So again, what this identifies for us is that whilst voice banking has its place, it's not always the preferred medium of communication for all patients with motor neurone disease. And this is what has really motivated my research within this area. So what do we know currently about speech treatment in motor neurone disease? And unfortunately, the answer is we know not very much at all. There are some very limited historical findings which have looked at targeted speech exercise for people in motor neurone disease. I've recently conducted a scoping review of the literature, and I've identified 2 studies. The first was in 1979, the second in 2001, so eons ago. And they were 2 individual case studies that looked at different tongue strengthening exercises and an intensive treatment program that was designed for people with Parkinson's disease, and looked at the application of those techniques in people with motor neurone disease with negative outcomes. But bearing in mind that these were really only 2 case studies, so looking at 2 individuals with MND. But this then instigated the belief that active speech exercise was contraindicated in motor neurone disease. More recently, a review of the literature has found 2 new studies, both in 2022, that have looked again at active speech treatment or exercise in motor neurone disease that have demonstrated positive impacts on the speech outcomes that were measured. So again, these are both small cohort studies, not randomized controlled trials, but a good start towards looking at how we can tailor interventions for motor neurone disease patients in terms of speech rehabilitation. So the first study is a Russian study that looked at music therapy to enhance respiratory, phonatory, so laryngeal or voicing function, and resonance focus, so reducing that hypernasal quality to the speech. It was quite an intensive program involving 6 weeks of treatment, 2 one-hour sessions per week, with positive outcomes on the speech measures taken. The second study involved 5 weeks of treatment with 5 45-minute sessions, so 1 session per week, again, focusing on multiple speech subsystems, so respiration, phonation being at that laryngeal level, resonance, that soft palate function, which determines the amount of nasality in speech, and then also looking at prosodic speech patterns, or that intonational pattern to the voice that we hear in healthy speakers. So what this information suggests is that mild to moderate exercise in MND may actually be beneficial to preserve motor function. And there are other studies that have looked at or that have more robustly investigated this hypothesis with randomized controlled trial designs using expiratory muscle strength training versus a sham condition. So some of you might already be familiar with expiratory muscle strength training. It uses a device where the person is required to expire or exhale against resistance. And this particular study in 2018 looked at expiratory muscle strength training versus a sham condition or a placebo condition, where the person utilized a device that did not provide that resistance to or on exhalation. And the results of this study were that there was an increase in maximum expiratory pressure and, interestingly, swallowing efficiency and global swallowing functioning in people that were using the authentic expiratory muscle strength training technique. There's also been a further randomized controlled trial in 2021 that looked at combining aerobic strength and flexibility training in people with motor neurone disease as compared to simply home-based stretching exercises. And the results of this randomized controlled trial were that there were superior outcomes for the group that combined aerobic strength and flexibility training in terms of their overall respiratory function, their mobility and well-being with this combined program. So the results thus far, these very preliminary results of a range of sort of very small scale studies, suggest that mild to moderate level exercise may actually be beneficial in preserving motor function in MND. We also know that in other neurodegenerative diseases, active speech exercise can be effective in improving speech function and also maintaining function over time. And in speech pathology, the LSVT LOUD program, which was designed originally for people with Parkinson's disease, has been sort of the most widely researched treatment program in speech pathology over the last 30 years. I'm not saying that people with motor neuron disease are appropriate to engage in this particular treatment, but what this demonstrates is that we can individually tailor treatments based on the neuropathology that presents before us in an effort to improve speech function or preserve speech function over the course of a neurodegenerative disease. But in motor neuron disease, this area of research is really untapped. Which brings me to the research that I am currently leading, called the Save Our Speech, or SOS study. And the aim of this study is to better understand speech changes in motor neuron disease by doing a number of things. The first of which is to identify what we call biomarkers or objective markers of disease progression in motor neuron disease, in speech decline, and in functional communication loss. So the study will be using quite sophisticated computerized analysis of recorded speech samples to look in a really fine-grained way at how speech changes acoustically, or the way the speech signal sounds over time, and then how those markers relate to the reported changes in functional communication loss that people with motor neuron disease experience. And we'll also be looking at identifying markers of speech fatigue in motor neuron disease, looking at speech stability and variability in motor neuron speakers by putting participants through a range of tasks that allow us to work up a profile of motor speech impairment within the population. So what is involved in the study, for anyone that may be interested? It will involve online speech sample collection sessions over a period of 8 months. So participants will be monitored over a fairly extended period of time. And this is necessary in order to capture the changes that may be afoot. The benefits are that participants do not have to leave their own home, that all of the data will be captured via a telehealth platform similar to what we're using this evening via Zoom, but purpose-built to record speech samples during those individual sessions. It does involve quite a level of commitment, with 27 online data collection sessions over a period of 8 months, with an average session time of between 45 minutes to an hour. As I've said, all sessions are going to be conducted online via video conferencing with a speech pathologist, and participants will be asked to complete a number of speech tasks during every session, as well as to answer a number of questions or complete surveys with the support of the speech pathologist in relation to the effectiveness of your speech at the time that that session is being conducted. What's in it for potential participants? The study itself is purely observational. So we are really at this stage looking at observing changes in speech function over time. So there are no direct benefits for participants in relation to speech function for this particular study. But what this preliminary work will do is to provide very important insights into the rate of speech decline and the pattern of speech decline that contributes to the loss of functional communication in people with MND over the disease course. And this research provides a really important step for the discipline of speech pathology in developing more objective measurement tools, which will enable us to more accurately determine disease diagnosis, to monitor the progression of disease over time, and also to monitor speech treatment responsiveness. Responsiveness in relation to behavioural treatments that speech pathologists may develop, and also responsiveness to drug therapies in terms of bulbar function and speech function in a more detailed way. So what are the volunteer requirements for anyone that might be interested? People need to be, of course, over 18 years of age and have a diagnosis of motor neuron disease. You need to have adequate memory and attentional skills to engage and participate in the online data collection task, because the technical setup, although not complicated, can be a little bit challenging at times. You are, or you need to have either normal speech or some speech change that is associated with the disease, but participants would need to still be using natural speech as their primary means of communication in order for us to monitor speech decline over time. At the moment, the study is ethically cleared for participants in Queensland only via the Royal Brisbane and Women's Hospital MND Clinic, the Prince Charles Hospital MND Clinic, the MND Association of Queensland, and the MND and Me Foundation. And importantly, people have to have basic computer skills, which most of us do in this day and age, but importantly, access to a device. So either your own personal computer or an iPad, an email address, and an internet service with adequate internet speed for the teleconferencing platform to operate effectively. If anyone is interested in participating in this research, I would love to hear from you. My email address and phone number are listed here on the slide, but if no one is able to take that down while I'm chatting, I'm sure that Gethin would be happy to connect anyone with me that may be interested in the study. So thanks everyone for the opportunity to share this information with you, and I hope to hear from some of you very soon.
Thank you, Brooke-Mai and Derik and Steph. So yes, if anyone is interested in participating in any of these studies, please get in touch with us if you did manage to get Derik or Brooke-Mai's details down, and we'll put you in contact with them. So if Derik and Steph and Brooke-Mai, you want to get your cameras back on, we'll jump into some Q&A. A question here came from Peter Wright, a really good question actually, so it's more for Brooke-Mai. So it's how does this sort of study relate to what I think it's the ALS TDI are doing with their precision medicine program? I don't know, you look like you're nodding, so you're aware of that. Because they have quite a large scale collection of this sort of detail. Will you be able to sort of compare your results in with that, or how different, similar is it?
That is a great question, and I absolutely have connected with ALS TDI in the last few months. The way that they collect their data, so in the sort of open access database, they don't actually have raw speech samples. And the acoustic analysis that I will be looking at is really looking at sort of feature-based analysis of certain acoustic features of speech, which their particular research hasn't looked at. So they very graciously agreed to share their raw data files with me, and we will be examining those with our sort of more fine-grained acoustic analysis in the next sort of 6 to 12 months, depending on how long it takes us to get ethical clearance and agreements in place. But yes, absolutely on the radar, and hoping to collaborate in terms of sort of machine learning approaches to predicting speech loss in MND.
That's brilliant. Yeah, I think that's the best thing we could do, is to make sure all our research ties in as much as possible to other large-scale projects around the world. I think that's really critical that we all talk to each other a lot. It's a question for both of you, really. Either with, or three of you, sorry, Steph as well. You know, either sort of appetite changes or even voice changes. Do you hear some reports from people with MND or their carers, sort of family members? Can it be an early indicator of changes, perhaps rather than other sort of physical functional changes? Can it be a sort of that canary in the coal mine type thing for either appetite or speech?
Derik, do you want me to speak to that in terms of swallowing and speech, or would you like to go first?
Absolutely. I'll jump in after you, Brooke.
Sure. Right. So absolutely. So obviously changes in voice quality, so hoarseness or weakness or reduced volume, can certainly be indicators of swallowing dysfunction, because the vocal folds within the voice box close together when we swallow to protect the airway and prevent things from sort of spilling down when they shouldn't. So changes in voice function can, not in everybody, but can certainly be an indicator of swallowing dysfunction in people with MND. But on the flip side of that, you know, sometimes there is no correlation at all. People can have vocal changes without any changes to swallowing function. So I think, has that answered the question, Gethin?
Thank you. Thank you. Anything on the appetite chain?
Yeah, so I think we have to be very careful when it comes to change in appetite. Many things can lead to change in appetite. And generally speaking, as we get older, we also tend to have our appetite change as well. So in terms of canary in the coal mine, I don't think that a change in appetite is necessarily anything to be worried about. Although quite often we'll find that, and this is not just MND, that people will lose appetite if there's something wrong. And it's whether or not that change is persistent and it leads to weight loss. That's really the important thing. And that's really what triggers you to go and see your GP or to go talk to somebody and figure out exactly why you've lost interest in food. And sometimes people don't even know that they've lost interest in food. It's not until they recognize that they've lost weight that something is going on. In fact, many of the people we talk to with MND, they are well aware that they've lost appetite, but they're not aware of the fact that it's actually impacting their weight.
And is there any correlation with any thyroid changes with MND at all? Because obviously that's quite a key player in appetite metabolism.
Yeah. So the thyroid gland is very important in regulating metabolism. Certainly, we've incorporated a lot of people into our studies that had thyroid problems, Hashimoto's, for example. But generally speaking, no, that's something that presents clinically. People, when they're aware of it, they see their GP and their doctor, and they get good treatment for it. And so that's managed very well. So in this instance, the change in appetite are quite distinct and different from changes in their thyroid function.
Right,
Yeah.
so there's not a correlation. There's no reports of thyroid changes within MND at all.
I haven't looked at any specific reports. We certainly have had a handful of people with thyroid changes present. Subclinical changes in thyroid is very, very prevalent. A lot of people will have subtle differences in their thyroid gland, but it's a very hard thing to really investigate specifically. And certainly in terms of metabolism, there's no evidence suggests that it contributes to the change in metabolism that we see in MND.
So this question is probably perhaps a bit more for well, both of you, for Steph as well. The way, how can we target this then? I mean, you talked about perhaps ghrelin as a potential target. I mean, I guess you always hear about drugs to make you lose weight. Are there drugs that make you gain weight or increase your appetite that are out there in the clinical?
Yeah, so there are many drugs that people are trying to introduce to encourage weight gain. One of the most popular, most prevalent used drugs is a drug called amitriptyline. All of these drugs are variations on ghrelin. Ghrelin is the only hormone in the body that actually makes you hungry. So it's this lone hormone. The rest of our bodies are designed to stop eating, which is quite ironic because we need to eat to survive. So in cancer cachexia, for example, drugs like amitriptyline are very effective in maintaining body weight or encouraging body weight. But the problem is that there's a limit to what they can do. It's kind of what motivated us and driven us to start looking at some of these other variations on drugs. We are working with a drug company overseas that have another drug that works very well to regulate things like growth hormone. Growth hormone is regulated also by ghrelin. We're testing now whether or not that particular drug can also help maintain body weight. And have other biological actions that might be beneficial in people with MND.
All right, we've got a few questions here about Brooke-Mai's trial as well. Can people still be accessing SLP therapy while they're participating in the SOS study?
It would depend what kind of therapy it was. Technically, no active speech intervention, but the majority of recommendations for people with MND at the moment are really compensatory and AAC. So I would certainly be keen to talk to anyone who's interested, but we would sort of look at that on an individual by individual basis. Anyone that's having expiratory muscle strength training, no, at this juncture would not be a candidate for participation.
Okay. How did you choose the 8-month time frame and the 27 sessions?
The 27 session revolves around looking at a time point at the beginning and end of each month. And then there's a second month where we look at a number of additional tasks to capture fatigability, variability, etc. So that's really formulaic. The 8 months was really within the confines of the funding arrangement. I would have liked to have looked at people for 12 months, but we do know that particularly in people with bulbar onset, that we can see quite significant changes within sort of a 6-month period. So we are, or I am convinced we will capture change within that time, but added some additional time in order to look at people in a more longitudinal fashion.
Okay. Great, thank you. Just realised we're running a bit late. So one last question here is for Steph and Derik. Is there any difference in appetite or weight loss between those with bulbar MND with no overt swallow impairments and those with severe actual dysphagia?
Okay, so Gethin, that's a very tough one to answer because we didn't specifically look at that. Certainly there's going to be people with bulbous onset disease that also have poor appetite. I think that's a guarantee. What the studies have shown is that bulbar onset disease in people with significant bulbar dysfunction aren't necessarily the ones with loss of appetite. It's everyone else. There's another question in here, associations with breathing. Having impairments in breathing most definitely in our studies show that it impacts appetite. So if you can't breathe, it's very difficult to also eat at the same time. It slows down your eating, which of course helps you feel fuller earlier. So if you eat slower, you're not going to eat as much. And then of course, there are other factors that can have a big impact on your appetite as well. I know we're out of time, but there was one question on high-fat diets, which I think we should really just quickly address. There is a study out there that shows that high-fat diets can have an improved effect, can benefit people with MND, but it's only a subgroup of people. These are the people who are at risk already of losing weight, struggling to meet their calorie intake, and it's also those individuals who had an aggressive form of disease. So in this instance, certainly going on a diet that's rich in calories can have benefits, but you need to be at risk of weight loss to begin with.
Okay. What we'll do for there's a few questions we didn't get to tonight. We'll collate the questions, send them on to Derik, Steph, and Brooke-Mai, and we'll get some answers, and we'll just make sure those answers get back to the people who asked the questions. We might even pop them on Facebook so everyone can see the answers as well. Okay, so thank you both. Very much appreciate your time tonight. And obviously, it's topics that really tweak the interest of our audience, hence the string of questions. Anyone listening tonight will get a copy of the recording, a link to the recording. If you want to watch it again, feel free, and also send it to arrange your contacts as well. I'm sure everyone else will enjoy this as much as we did. They're also, the rest of our state of play are also on that link as well. Just the latest research directions is out if anyone's interested. And we'll also be running the second Australian MND Clinical Research Learning Institute, which is a 2-day online program that allows attendees. It's specifically aimed at people in the MND community, carers, patients, family members, to teach you a bit more about the research process and how new treatments are developing. That's going to be running on the 13th and 14th of November. It's all online, so you can do it from your couch or your office desk, and it's welcome to anyone. So I'd just like to say thanks again to everyone, to Brooke-Mai, Derik, and Steph, and good night all, and thank you for dialing in. Very much appreciate everyone's attention.
Thanks, everyone. Thanks,
everyone.
Kevin.
Bye-bye.
Good night.